Everyone, and welcome to today's lecture called the Infection Prevention Module 309, and it is titled Outbreak Investigation. So this lecture that we will be presenting today is a collaboration with the Texas Epidemic Public Health Institution, or TEPI, and P2R Consortium, along with some additional presenters from DSHS, and they'll introduce themselves in a minute. So this lecture briefly goes over how to conduct an outbreak investigation in acute care settings, talking about what the roles and responsibility of the state health departments, and really highlighting the importance of collaboration during patient transfers in long-term care facilities. So if you're new here or if you're a returning attendee, we say welcome. Today's lecture will be recorded. Within a week or so, you will get a link to access the recording along with the slide deck. So be patient for that. So again, today's lecture is recorded and you will receive a link along with the slide deck emailed to you in about a week or so after today's presentation. So if you're new here, I'm one of today's speakers. My name is Dr. Kayla Rush. I have my PhD in epidemiology and my master's in public health. I'm also certified in infection prevention and control, public health, and healthcare accreditation. I'm a seasoned IP. I have experience working in acute care, long-term, and skilled nursing facilities in Texas, New York, and in California. And I am co-presenting with 3 individuals from DSHS, and I'll let them introduce themselves.
Hi, everyone. My name is Varsha Misra. I am a DSHS HAI epidemiologist. I'm currently supporting the South Texas area, Region 11, and I also help with the Houston area, Region 65 South, along with my co-EPIs, who I will pass on to.
Thank you. Hi, everyone. My name is Courtney Lopez, and I am an HAI epidemiologist with Public Health Region 65 South, so the Houston and Greater Houston surrounding counties, and I'll pass it on to Kajal.
Hi, everyone. My name is Kajal Amin. I am Courtney's co-epi for Region 65 South, so same region, same counties, and we're with the Texas Department of State Health Services Healthcare Safety Unit. So we're excited to be here, and we thank everyone for joining this webinar, and we hope you learned something new today.
Great. Well, thank you. So a little bit about us. So this is hosted by the Texas Epidemic Public Health Institution, or TEPI, and our goals are really to help keep Texas safe and build a more resilient community to help prevent the next infectious disease outbreak. So we have multiple cores from communication, early detection, readiness, along with other different concentrations. And at the end of the slide, there's more information, a QR code, and some links if you want to check out different components of TEPI's organization. So today's lecture has been approved for continuing education hours. At the end of the slide deck, there is a detailed slide of saying, providing instructions of what you need to do to obtain continuing education hours. So we'll go into that next. So to obtain your continuing education hours, you will need to follow the instructions that are listed in the slide at the end of the slide deck that says continuing education hours. You will need to complete this lecture, so you will need to watch it and be a part of it for 100% of the activity. Conduct and complete the learning assessment, which you'll need at least an 80% on, and complete the post-survey evaluation. This lecture has been approved for continuing education hours for medical education, or CMEs. It's also been approved for nursing continuing education hours, or NCPDs. It's also for certified health education specialists, certified public health individuals, and registry sanitarians. It's also been approved for continuing education hours through the Board of Infection Control for AIC or CIC holders. The other presenters do not have any conflict of interest to disclose. One thing I need to disclose is that I am a consultant for BD. However, this lecture has no mentioning of products and kind of talking about any relations regarding that company or that affiliation that I have. So this is just more for continuing education hours of that we are not endorsing any product through these areas, and there's no continued conflict of interest between all of us. So let's get started. I'm first going to do a quick review of investigations in acute care settings. So the first thing that you want to do when you are starting an outbreak investigation within your facility, especially in acute care, is really looking at the idea and confirming the presence of an outbreak. You can use different components of the epidemiology triad, which is the relationship between your agent, which is it a bacterial, virus, or prion, your host, so is it in humans, and then also your environment. And a different other model that you can use is the One Health model of kind of looking at the relationship, which is the relationships between animals, humans, and our environment. So the first step that you want to do in the investigation is confirm the presence of an outbreak. And you can do that by really looking at your surveillance data. So looking at your different cultures, previous admissions, talking to your staff, especially if it's a new or emerging pathogen. So this might be a new organism that we don't have a test, just like we've seen over the last few years with COVID-19 and then with Mpox. Definitely knowing and talking with your providers in all areas of, hey, do you see something? Are you seeing an increase of patients presenting with certain signs and symptoms? Have you had ideas of that maybe there's something else? Have you read anything either at the state level, the federal level, or at the local level of that there could be an emerging pathogen, or you have information of a new pathogen or reemerging pathogens that has now started being in facilities? So your first step is always confirm the presence of an outbreak. So is there something going on in your facility or not? The next step is that you want to identify your investigation team and resources. So if you think you have a problem, make sure that you look at internally of, who do you need to inform this? This usually involves your leadership. So making sure that if you're an infection prevention professional, talking to your manager or director of infection prevention, talking maybe to your medical director of infection prevention or infectious disease. Or if you report up to quality or nursing, making sure that level of C-suite is aware that there could potentially be an outbreak. And at this stage, you're just starting to see an influx of signs and symptoms or a certain test result within your community that you serve. Also, depending on what the pathogen is and the severity of, making sure that then if this is an outbreak, you'll be needing to go outside of your system and notify local or state public health, depending on the organism. So first, at step 2, you're just having those conversations of making sure that your leadership within your organization knows that, hey, there could be a problem. We are investigating it. And also at this time, asking about what resources you need. Is that, potentially we want to culture more things. We need to stop certain things. We need to isolate an area, kind of starting to talk about the logistics so that they're a little bit aware of like, hey, this could be a financial impact. This could impact staffing. This also could be impact operations at our organization. So having those conversations early, making sure everyone is aware of the situation is really beneficial. Then it goes into step 3 of verifying the diagnosis. So now that you think something is going on in your facility, you have verified it. So that's either with imaging or with culture, you have a test result for that specific pathogen that you're seeing within your organization. And so a good point with the verifying the diagnosis is depending on what type of microbiology test is needed. Do you need it? Is that an in-facility test? Is that an outside of facility test that you might need to send out for further isolation for a specific strand or a serotype? Making sure that you know the difference between a presumptive positive and a positive too. So having all of that conversations is at step 3 is really important. And then based on the information that you gather from the first 3 steps, you'll start developing your preliminary case definition. And this first case definition should be broad enough where that you're not excluding information, but narrow enough that you're not including everything under the sun. So you want it to be kind of that nice medium that it's broad enough where you can see certain signs and symptoms for that certain pathogen, but not everyone. So it's really hard to identify if there's a problem if you're screening every single person under that kind of like preliminary case definition. So you want to be not too broad, but not too specific. And then with that information, now you're going into step 5 and you're alerting administration that now you have confirmed your thoughts from the step 1 and 2 have been confirmed that you do have an outbreak of a certain pathogen. So you're talking about, operation disruption. Are you shutting down the service line? Are you having to bring more staff in? Are you changing the flow of your operation? You're letting healthcare providers know of, hey, we're starting to see this. We've had an uptake of this pathogen. Please be aware when you're screening patients, for certain signs and symptoms or a certain location that they're from, that is all being disseminated clearly to your frontline staff and your clinicians. And then you're also then communicating with local, state, or federal public health as directed. It's always best to start at the local level when you're reaching out to our local public health individuals, and they will direct you of what needs to go forward. So if that's them coming in and doing a site visit, if you need to do certain collection, if there's isolation requirements, if there's other documentation that you need to submit to them, that was all discussed. And during that time when you're reaching out to them, you can also get information of, do they know of other facilities in the area or in the state or in the country or regions that are seeing this pathogen, such as, for this lecture, we will be talking about C. auris in detail. We're really looking at what type of, signs and symptoms, or if they're asymptomatic with C. auris. So they can provide you with some materials, some resources for your lit review, or direct you to go onto the CDC site or DSHS site of looking at signs and symptoms so you know what to look for. And that will go into your step 7, which is developing a methodology. So now you're looking at signs and symptoms, you're ordering tests, you're placing isolation, you're kind of doing all the things to identify them, order appropriate tests, and then get them on treatment appropriately. And during that time, when you are collecting and getting more patients with that certain type of pathogen of interest, you're preparing a line list. So you're collecting data on those patients that are presenting. Where were they from? Have they been in other healthcare facilities? Have they traveled anywhere to an endemic region? Have they been exposed to any individuals with this pathogen? And then you're plotting out your epi curve, which I'll show you next. So here's just an example from the CDC of their line list template. It is a free resource, and the link to that is in the references and resource sections of this lecture. Some common things to look at is admission date, where they are in your facility, looking at their race, age, comorbidities, did they die, lab results, surgical procedures, imagings, dates of isolation started, dates of discharge, previous admissions, previous healthcare, any antibiotics received in the last 30 days, or any antivirals or any antifungals, depending on the pathogen of interest. And then also, tailoring the line list of other things that are maybe specific for your population that you're seeing, or the community that you serve. And then you'll plot your lines, your case numbers, which you'll see here, which is your epidemic curve, which will show how many cases in a given time. So you can see the analysis over time, how many cases that you're having on a specific day, or in a specific unit. And then you'll go into your observation, which is looking and reviewing potentially impacted patient care activities. So this is now where we're going to be monitoring what's going on with these patients. So we're making sure that isolation, hand hygiene, PPE compliance is great. We're also going to be observing processes. We'll be interviewing staff, asking them, do you always do it this way? Is there possibly another way you do it? Is it standardized? Does everyone do it in the same? Does every unit do it the same? So making sure you're having those questions and really facilitating that conversation. And during this time, you want to make sure that you're open, you're receptive. If the staff feel like you are blaming them, they might not be forthcoming with information, especially if there's deviation or, if someone does it one way versus another. So you want to make sure that you are really have done the groundwork of building those relationships and then having these conversations appropriately and being very open. The next thing you'll go consider is if you want to do any gene sequencing, or is this recommended from talking to local or state public health agencies? Are they wanting another additional sample taken in for sequencing? Or is this, you're thinking that you need to do environmental or healthcare personnel sampling? This is dependent on the specific pathogen. For C. auris, which we'll be talking in detail later today, this is not recommended for C. auris, but it might be of interest on other pathogens, or depending on what type of outbreak that you have in your facility. And then the next big step is implementation control measures. So you want to make sure that you're implementing rooming assignments, isolation, compliance, hand hygiene, making sure that you're doing everything to stop or control the spread and that no more patients or staff members are affected by this outbreak. And this is just kind of a little reminder that during these steps, a lot of things can be evolved and changing. Depending on your organization, you might want to talk about patient assignments and ratios, especially if this is emerging pathogen, of making sure that your patient assignments in the state of Texas, we don't have nursing assignment ratios, so it's kind of up to every facility of then making sure that they are aware of if you're taking care of this patient, which has a highly transmissible pathogens, there's really good compliance, or maybe they're only assigned to that one patient, or you're cohorting patients, so they're only working with patients that are affected with that certain pathogen. Also be mindful of talking about patient flow and throughput, making sure that we know that under the investigations, additional steps, there's more donning and doffing use, that those are taken into consideration. And if there's an exposure event, that you might have to do a contact trace, going to units, going to other staff members. And to get more details on that, previous lectures, module 207 and 208 go into that detailed, very, very detailed lectures. So if this is a new concept to you, I highly recommend looking and referencing those lectures. And the whole point of the epidemiology investigation is to really just identify the problem, implement control measures, evaluate it, making sure that what you're doing is effective and that you keep evaluating as more information becomes light, especially if this is a new pathogen that we have not seen before. As the science evolves and changes, that we are aware of what's going on, and we're changing our case definition, our recommendations based on local, state, and federal guidance appropriately. And then after the investigation, you'll do a follow-up, which is our defining and redefining case definition. So as we talked about previously, this very broad case definition that you begin at the beginning of the outbreak investigation, depending on the time, there could be more science, you might have to redefine it. So going back and making sure that you're looking at, what did you say you're looking for? Is there other signs and symptoms? Do children present differently than adults? Making sure that you're taking that into consideration. And then you want to continue finding cases, doing your surveillance for a set period of time. As the outbreak severity and length continues on, making sure that you're setting metrics appropriately, kind of using those SMART goals, that it's specific, measurable, achievable, timely, and realistic, that you're setting surveillance goals of looking at cases for weeks to months to 6 months to a year, and then you are reviewing control measures. Is this working? Is this not working? Is this sustainable? Is this effective? Is this aligned with the new guidance that has come out? And then maintaining those activities until a set period of time. And then lastly, consider whether an analytical study should be performed, of doing a long-term follow-up of changing or publishing your results of lessons learned during that. So now I'm going to kick it over to our speakers for their section. Courtney, you're on mute.
Thank you. Hi, everyone. In case you joined late, thank you for joining the webinar. My name is Courtney Lopez. I'm a healthcare associated infections epidemiologist with the Texas Department of State Health Services Healthcare Safety Unit. I am joined today by my HAI epidemiology colleagues, Kajal and Varsha. Today, we're going to discuss how we investigate healthcare associated infection outbreaks with an emphasis on Candida auris in acute care hospitals. Next slide. So we plan on discussing the background of healthcare-associated infections and the reporting requirements for our notifiable conditions list in Texas. We will also discuss the impact of Candida auris and what it has done in our healthcare in our state. We will also share key takeaways from public health investigations that we have conducted in collaboration with our healthcare facilities. Next slide. So first, we're going to begin by discussing what healthcare-associated infections are and some examples of investigations we have worked with. Next slide. So what are healthcare-associated infections? They are infections that patients get while or soon after receiving healthcare. Each day, about 1 in 31 patients contract at least one infection in association with their healthcare. And each day, about 1 in 41 nursing home residents contracts at least one infection in association with their healthcare. Next slide. Now, these are some examples of healthcare-associated infections and outbreaks our team has investigated. Some of these conditions are reportable via the Texas Notifiable Conditions List, which we will get into further in the presentation. Others are for non-reportable conditions. However, facilities will sometimes notice an increased number of an organism, or the organism was being detected in an unusual place, such as a NICU or transplant wing, or detected in patients with a surgical device in common. Other times, patients have tested positive for an organism in a short amount of time and have had overlaps in stay or procedures, and facilities reach out to us to have those investigated. Next slide. Now, in Texas, we do have a notifiable conditions list that mandates how and when diseases need to be reported to public health. Next slide. So the Texas Notifiable Conditions List is a list for healthcare providers and laboratories. It's a list of organisms that are required to be reported to the state of Texas or to public health. The Texas Administrative Code 97.3 lists reportable notifiable conditions and the minimum information that must be reported for each of those conditions. Additionally, any outbreak, exotic disease, or unusual group expression of disease should be reported as soon as possible, even if it's not immediately notifiable. Next slide. Here is an excerpt from the 2025 notifiable conditions list that I mentioned previously. The Texas notifiable conditions list has over 60 conditions that are required to be reported, and it specifies when they need to be reported. There are certain conditions that can be reported within 1 week, such as listeriosis or malaria, but others are required to be reported to public health within 1 workday, and there are others that need to be reported immediately. In addition to these specific reported conditions, as said previously, exotic diseases or unusual expression that may be a public health concern should be reported. If a facility is suspecting an outbreak of HAIs, they should report it to public health. An example we can use is MRSA. So while MRSA is not a reportable condition in Texas per the notifiable conditions list, an increased cluster of MRSA in a NICU would be considered unusual expression or a cluster and should be reported to public health for further investigation. Next slide. This is just a continuation of the Texas Notifiable Conditions List. As you can see, Candida auris is mandated to be reported in Texas to public health within 1 workday of it being suspected or confirmed via a lab report. Next slide. In addition to Candida auris being mandated by the Texas Administrative Code to be reported to public health, the Texas Administrative Code also mandates that all isolates of Candida auris must be submitted to the DSHS laboratory for further testing. Candida auris is a targeted organism for surveillance by the Antimicrobial Resistance Laboratory Network, or ARLN, as you'll see us mentioned throughout the presentation, which is a coalition of public health labs designed to sequence and test multi-drug resistant organisms. Our DSHS lab is part of the Antimicrobial Resistance Lab Network. If you have questions about submission of Candida auris or have not been doing this or are unsure of the next steps, please reach out to Texas ARLN at dshs.texas.gov to work with the lab to begin those submissions. And we will have a slide at the end with more contact information for everyone to take a screenshot of. Next slide. So this map is referring to the ARLNs that I discussed previously. We in Texas are part of the Mountain Region Antimicrobial Resistance Laboratory Network. We do send Candida auris isolates we receive to the ARLN in Utah to do antifungal susceptibility testing to determine if there is pan-resistance or resistance to antifungals. Next slide. In summary, Candida auris is a mandated reportable condition, and isolates are mandated to be sent to the DSHS lab. Once the isolate is received, DSHS confirms resistance patterns. DSHS will also confirm that it is in fact Candida auris. If needed, those isolates can be sent to Utah for further antifungal testing. In some instances, the isolate can be sent to CDC if unusual characteristics are identified, such as resistance to multiple antifungals. Next slide. It's important to know the background of Candida auris and its impact on healthcare. Next slide. So why is Candida auris a problem? Candida auris can cause severe infections with high mortality. It can cause bloodstream infections and even death, particularly in hospitals and nursing home patients with serious medical conditions or comorbidities. The mortality of invasive infections is estimated to be 40% within the first 30 days. It's often resistant to antifungal medications. The common antifungal medications used to treat other Candida infections often don't work for Candida auris. Some Candida auris infections have been resistant to all three classes of antifungal medications, the paulines, the azoles, and the echinocandins. Next slide. Candida auris is becoming more common. Although Candida auris was first discovered in 2009, it has spread quickly and causes infections in more than a dozen countries. It's also difficult to identify. It can be misidentified as other types of fungi unless specialized laboratory testing is used. This misidentification might lead to a patient getting the wrong treatment. Next slide. As discussed a little while ago, Candida auris can be difficult to identify because it can sometimes be misidentified as a different organism depending on the type of test being used. This table just summarizes quickly and is also found on the CDC website, different tests that have misidentified Candida auris as a different Candida species. Next slide. Candida auris can easily spread in hospitals and nursing homes. Candida auris has caused outbreaks in healthcare facilities and can spread through contact with affected patients and contaminated surfaces or equipment. Good hand hygiene and cleaning in healthcare facilities is important because Candida auris can live on surfaces for several weeks. Next slide. Now, I do want to transition us into talking about Candida auris infection versus colonization. It's important that we distinguish infection versus colonization when we talk about Candida auris. Candida auris infection means the organism is causing symptoms of clinical disease. Candida auris can cause infections in different parts of the body, such as the bloodstream, open wounds, and ears, to name a few. The symptoms depend on the location and the severity of Candida auris infection. Symptoms may be similar to those of an infection caused by a bacteria. There is not a common set of symptoms specific to Candida auris infections, and patients with invasive infections are often already sick with other medical conditions. Next slide. Now, a patient can also be colonized with Candida auris. Colonization means that this organism is found in or on the body, but is not causing symptoms of disease. Someone who is colonized can still transmit Candida auris onto surfaces or objects that they come into contact with, which can then spread to other patients in the environment. There is no decolonization protocol for Candida auris. There is currently no data on the efficacy of decolonization for patients with Candida auris, such as the use of chlorhexidine or topical antifungals. Once a patient has been identified as being colonized or infected, the recommendation is that they remain on contact precautions for the duration of their admission and any future admissions to an acute care facility. It is not clear at this time how long someone can remain colonized, but there has been data showing individuals testing positive up to 2 years after an initial colonization or infection, even with intermittent negative results during this time. Next slide. Now, pulling from an earlier slide about the mortality of invasive infections, 5 to 10% of colonized patients do develop bloodstream infections. The major risk factors involved with developing Candida auris infections are individuals who require complex medical care, have invasive medical devices such as ventilators or central lines. Individuals who have frequent or prolonged stays in healthcare facilities are also at a higher risk. And individuals who have had recent exposure to healthcare in an area known to have Candida auris transmission are at an increased risk of developing an infection. Next slide. Lastly, I want to show a larger picture of how this fungus has spread. This is a map of Candida auris clinical cases in the United States. This is the most current data available on the CDC's website publicly. From 2016 to 2023, there have been 10,788 clinical cases. There were 9 clinical cases from 2013 to 2015 that were reported retrospectively. Clinical cases are those in patients with Candida auris identified in samples tested to find out the cause of an infection. This sample can be taken from either an invasive body site, such as blood or spinal fluid, or a non-invasive body site, such as wounds or urine. There were an additional 22,931 screening cases that are not shown on this map during that same time period. Screening cases are those in patients who receive a positive Candida auris result from a swab collected to test for colonization. Now, Texas has had more cases when compared to most other states. And we will now discuss how Candida auris is investigated by public health. Next slide. So I will go ahead and pass the presentation of Varsha to go through the public health investigation process for outbreaks and the role that HAI epidemiologists play during these public health investigations.
Thank you, Courtney. All right, so as Courtney said, we'll be going through the public health investigation process for outbreaks. Next slide. All right, so this is the local health department and regional public health coverage map that Texas created for DSHS. So this map can be used to figure out whether a local health department or regional health department provides public health coverage for each city or county. So you can see here that there are 8 public health regions in Texas that are distinguished by these numbers. So 1, 2, 3, 4, 5 north, 6, 5 south, 7, 8, 9, 10, and 11. And this map can be used to identify the public health regions in Texas as well as the regional headquarters, which are in each region. And this map is available on our DSHS website to access. Next slide. So HAI epidemiologists wear many different hats during an HAI investigation. Some of the primary roles of HAI epidemiologists include being the healthcare infection prevention and control expert, conducting infection control assessments or ICARs in healthcare facilities. We respond to investigations and outbreaks in healthcare facilities as well as support local health departments with outbreak investigations. And then we often collaborate with stakeholders in different infection prevention and control activities. Next slide. So some examples of investigations that HAI epidemiologists respond to include infectious diseases transmitted in healthcare settings, novel or high concern antibiotic resistant organisms such as Candida auris or CREs, carbapenem resistant Enterobacterialis. We also deal with infection control breach notifications from accrediting and regulatory agencies. We assist with medical products or device contaminations and transplant or transfusion related infections. Next slide. We also tend to respond to bloodborne pathogen exposures in healthcare facilities, as well as healthcare facility environment issues. And then we often assist other public health programs with investigations that may occur in healthcare facilities, such as zoonotic conditions, vaccine preventable disease conditions, and tuberculosis. Next slide. So here we have a chart of the response steps that we follow as a HAI epidemiologist during an investigation. After notification of a positive lab result for an HAI condition, the first step that we have is to notify the facility and ensure that the proper infection control measures are in place. Next slide. So for infection control measures, we want to make sure that these are implemented promptly so that we can limit transmission throughout a healthcare facility and make sure that the patients stay safe. We'll go through some common infection control measures that we discuss with facilities to ensure that the proper precautions are in place. Healthcare facilities should conduct patient care duties last to reduce the spread to other patients. We also want to make sure that staff, patients, visitors, they're all educated on the organism of interest and that the appropriate infection control measures that correspond with the organism are relayed to these different entities. Next slide. So more infection control measures that we want to make sure facilities are educated on and implementing. So we have standard precautions. Standard precautions should be implemented for all individuals, regardless of diagnosis or their presumed infection status. Standard precautions include hand hygiene, PPE, appropriate patient placement, cleaning and disinfection, and more. We also have transmission-based precautions, or they're also referred to as isolation precautions, which are for patients who may be infected or colonized with certain infectious agents for which additional precautions are needed. So for example, if a patient came to a healthcare facility and had a positive lab result for Candida auris, they would need to be placed on contact precautions since they have a known or suspected infection that represents an increased risk for contact transmission. We also have enhanced barrier precautions, which are specifically for nursing home residents with MDROs, and these are implemented to reduce transmission of MDROs in nursing homes. Enhanced barrier precautions are different from transmission-based precautions in that the use of gowns and gloves are only for high-contact resident care activities, and these residents are not restricted to only in their rooms. They're allowed to go into common areas. Next slide. So here we have some signage examples of signs that should be posted outside a patient's room whenever they are on precautions. So you can see here we have the contact precautions. It shows that everyone must clean their hands, including before entering and when leaving the room. It also shows that providers and staff must put on gloves before room entry and then discard gloves before room exit. Same thing with a gown. Should put on a gown before room entry and then discard the gown before room exit. It's also important to not wear the same gown and gloves for the care of more than one patient. You want to make sure that you're switching those out as you see the patients. And then you want to make sure that you're using dedicated or disposable equipment and that this is reusable equipment that can be cleaned and disinfected before use on another patient. We also have the enhanced barrier precaution signage. So you'll see that this is just a little bit different, but same thing, everyone must clean their hands before entering and when leaving the room. Providers and staff must also wear gowns and gloves for the following high contact resident care activities. So this can include dressing the patient, bathing or showering the patient, transferring the patient, changing the linens in their rooms, providing hygiene, changing briefs or assisting with toileting, any type of device care or use. So whether it's a central line, a urinary catheter, feeding tube, tracheostomy, we want to make sure that gowns and gloves are used for all of those. And then also for wound care. So any skin opening that is requiring a dressing, same type of precaution should be used there. And then again, making sure not to wear the same gown and gloves for the care of more than one patient. Next slide. So we'll go to the next step in our response, which would be to ensure communication of infection status between healthcare facilities. So MDRO patients can often be transferred to other acute care hospitals or long-term care facilities, skilled nursing facilities to continue their care. When this occurs, it's very important that facilities are maintaining communication about the patient's MDRO status so that the receiving facility can ensure that they are placed on proper precautions once they get there. Next slide. So to facilitate this proper communication between facilities, DSHS created an interfacility infection prevention transfer form, which you can see here. And this was adapted from CDC's form that they created. And the purpose of this form is for facilities to use when transferring a patient to another facility. So information on the patient's MDRO status should be communicated prior to and during the transfer, and this form is intended to aid that communication between facilities. This form does not need to be sent to the local or state health departments. It is solely for the use of healthcare facilities to maintain communication with other facilities. So now we're going to go through the different components of this form. There's 3 parts, so this is the top section, and you can see here that you're able to put the patient's name, date of birth, and medical record number at the top. Next section is very important to fill out, so it's the transfer information. You want to make sure that it has the transfer date of the patient when they're going to another facility, what the sending facility's name and city and state is. The point of contact for the sending facility is important to mark on there because if the receiving facility has any questions or needs to check up on something, they have that information right there on this form. And then you also want to have the receiving facility name and their city and state on this form as well. So we know exactly where the patient is being sent from and where they're being sent to. Next slide. So as we go further down the form, there is a section for isolation status. So this is where you can check if the patient is currently in isolation or if they just need to be put on standard precautions. And if they do need to be in isolation, which type of isolation do they need to be on? Are they needing to be on contact plus hand hygiene with soap and water, droplet precautions, or airborne precautions? So this is probably one of the most important parts of the form so that the receiving facility knows exactly what to do with the patient when they receive them. There's also a section for significant infectious disease history, so you can mark whether the patient has a history of any known MDRO or infectious disease. And you can see here that there are some great options listed for you to check off. So Candida auris is on there, CREs, MRSA, all of these that you might want the receiving facility to know about the patient if they have a history of. Next slide. And then as we go down the form, we see that there's a section for signs and symptoms, so any current symptoms that the patient might be having, as well as any other risk factors. So does the patient have any indwelling devices, a central line, a catheter? Are there any cultures pending for the patient? And if there are cultures pending, when was the date collected of the culture, and when can the receiving facility expect to get those results? There's also an option to add any other medical administration records or additional comments so that everything that the facility might want to know about the patient is right there on the form. So next, I will pass it out to Kajal, and she's going to discuss the components of the healthcare investigation.
Thank you, Versha. So we've reviewed all of the resources that public health can support and how to ensure that interfacility communication can be facilitated before even public health can respond. We're now going to show you what actually happens when a public health investigation response occurs with our teams and what are we doing with that information that we're requesting. As a reminder, while we are visualizing all of these response steps, I want to emphasize that the word investigation can be daunting sometimes, and while it is a word that we use very frequently whenever we reach out to your facilities, we want to emphasize that the mission of public health is to improve health and safety. We're not here to be a regulatory service for your facility. We're not here to report you to Joint Commission, to HHSC, or any other accrediting agency. We're solely here to help you out to make sure that you guys don't even get to that point, and we can provide those resources to you. So don't let the word investigation scare you. It's just a formal way of saying that this is what we see on our end, and we're going to provide the resources that we can to help mitigate that transmission of that organism and ensure the safety of all your patients. So let's go through what an investigation is. Next slide. All right, so we began with the healthcare investigation. We're going to start by obtaining those medical records from the facility. This includes several critical components such as the history and physical, which allows our team to see what's that patient's baseline condition and that presenting illness upon admission. Not only for C. auris is this helpful for other organisms as well, this is going to help that team also come up with a differential diagnosis in the case that what we're investigating may not be the actual condition that we're going to report that patient with. We're also going to gather information regarding the discharge summary, the physician note. I particularly love the ID physician note, as you guys may have seen in your own records at your facilities as well. It's the most informative and the most helpful in terms of conducting that epi investigation for that patient in itself. We're also going to collect information regarding bedroom assignments. We want to see, where did this patient go throughout the entire healthcare facility? Are there additional areas? Are there additional patients that we're concerned about? We want to make sure that we're prioritizing these patients whenever we're doing the subsequent steps of this healthcare investigation. And I'll get into this, but such as the colonization screenings and follow up with additional healthcare facilities as well. All this information is essential for us understanding the patient's clinical background and risk factors at the beginning. Next slide. The second component of the investigation is that we're going to abstract from the medical records the history of any additional healthcare exposures. Key questions include, did the patient have any healthcare encounters in the past 30 days? This allows public health to respond to any additional facilities that we see not only around our jurisdiction, but in the state of Texas or even out of state. We want to see if this patient had any recent healthcare stay at any facility to ensure that there's no active transmission happening at that previous facility as well, or even the discharge facility. Did the patient share a room with any additional patients during this encounter? Public health will recommend screening close contacts of that patient immediately and ensure that the previous or discharge facility is aware, depending on the organism. In terms of Candida auris, for what we're illustrating throughout this entire webinar, is we are going to recommend screening those additional contacts and any close, which includes roommates, anywhere that patient's been in that room and there is another patient that may be at risk for contracting CORs via colonization or infection. We want to really make sure that we're finding them. I want to re-emphasize that the previous slide concerning interfacility communication. While public health is always here to help, mitigating the transmission by implementing precautions for patients needed on admission is really important, rather than risking the continuous transmission. If we don't communicate that information between our healthcare facilities before public health gets involved, we've already lost our goal in terms of seizing that transmission at the beginning. So I really want to emphasize, even before public health comes into the picture, we would really like facilities to communicate, and using the interfacility communication form is going to be the most helpful way and the most concise way to getting that information across from IP to IP, or even admission folks who are taking that patient into their facility subsequently after discharge. Next slide. So we went through the initial steps of the notification. All the notifications have been made to public health, and the healthcare investigation has begun. We've taken a look at all the medical records, so that proceeds us to our next step, colonization screenings. This not only includes the healthcare facility that we're actually investigating actively, but also additional patients that may have been identified throughout that medical chart abstraction. So for example, we're investigating an acute care hospital for a CORS patient, and we noticed that this patient was admitted from a nursing home one day prior to admission. We're going to go ahead and reach out to that nursing home and see if they were aware, if they had a CORS infection or colonization. Are there any additional cases? Is there any sort of public health support that we can provide to that nursing home? And we're doing this simultaneously with both facilities to ensure that that transmission is mitigated right at the beginning, before it gets into a bigger mess and into an outbreak where we may not be able to control that transmission thoroughly. Let's review what the key components of colonization screenings are and what our ARLN network can support with. Next slide. So colonization screenings, they play a vital role in controlling the transmission. The colonization screening protocol for CORs emphasizes the major points above, but one thing I really want to emphasize is that for CORs, these steps are crucial because colonized individuals may not show symptoms, but can still actively spread the organism. Our ARLN lab network is a great resource, not only for colonization screening support, but also for whole genome sequencing. So if you have any questions regarding colonization screenings, or even think that maybe there's sequencing that may be helpful to you understanding what's going on within your facility, we strongly encourage you using our resources and contacting your local public health partners to start that conversation and begin that entire investigation, and use all the tools that you have in your toolkit. Not everything has to be done by your facility in itself. We're here to help. We can provide those resources, and I know finances wise, it's always helpful if something's free. So please reach out to your local health partners or even us, and we can help you begin that entire investigation process for colonization screenings or whole genome sequencing as resources allow. The overall goal of screening is to identify patients as rapidly as possible and mitigate transmission more efficiently. At this step, we have identified who our priorities are for screening and our recommendations for the facility. But what is this going to look like term wise? So we're going to go ahead and go to the next slide, which brings us to retrospective and prospective surveillance. This is an essential step in our response, and I want to show you what that means for our facilities and our investigations. Next slide. So retrospective surveillance, it helps us look back and determine if there were any missed or linked cases. So we wanted to do a look back at that line list that you have. Were there any additional patients in different areas that we weren't aware of that we may want to prioritize for screening? Prospective surveillance allows us to monitor for new cases. Together, both of these actions provide a comprehensive view of transmission and assess the effectiveness of infection control measures over time. Our airline network is more than happy to help with this process as much as possible. So whenever your facility is conducting a colonization screening and you do need our resources, please reach out to your public health partners. It is a recommended step for CURS investigations, as well as other pathogens that are identified at your facility. Next slide. So now we're going to get to the infection control assessment. Simultaneously during the screening, we're also going to be conducting an infection control assessment. Our public health partners are trained to do these assessments on site at healthcare facilities, and it's formally known as an infection control assessment, but we call it an ICAR. And we use CDC tools to ensure that we're providing concise recommendations with not only regulatory agencies recommendations, but also CMS as well. At this slide, I want to re-emphasize that ICAR is non-regulatory. These visits are designed to help healthcare facilities improve infection prevention programs and reduce healthcare-associated infections. So let's take a look at what an ICAR assessment actually looks like at a healthcare facility. Conducting an infection control assessment is a structured method of identifying gaps in infection prevention. Infection control assessments are key tools we use to evaluate and strengthen infection prevention practices. So these ICAR tools that are linked over here on this slide, which you will be able to access after this webinar, has a whole entire toolkit of different CDC developed ICAR tools that you can actually implement within your facility as an IP or just to ensure that you guys are reporting and conducting those audits more frequently. The ICARs can be tailored specifically for certain conditions. So we can do proactive ICARs, but most of the time it is response-based in terms of whenever we're getting notified of a pathogen, and I'll explain the difference in a little bit. They can be prevention-based as well, like I said, and they're used in the absence of an outbreak. So if it is prevention-based, we do go a little bit more thoroughly and kind of mimic a Joint Commission survey or a HHSC survey where we'll go through all the different components such as laundry, dining, every single portion of that facility to see if we can provide any recommendations back to your facility. The goal is to assess the strengths of what your infection control program already has implemented, and we want to identify any opportunities for improvement. Sometimes we may not find anything, and that's never a bad thing. That's great for your facility that you guys are able to have such a precise and a great infection control program. But we're always here to be that third eye and help you guys out in terms of identifying any gaps that you may not be seeing with your team, and hopefully that helps stop the mitigation of the organism that's been identified. The CDC developed tools available online have various modules, so you can take a look at the different modules such as hand hygiene, high-level disinfection, injection safety, or even healthcare laundry. They have resources such as audit tools as well, which if you are looking for any audit tools, I suggest heavily to take a look at what's been published online. It's going to help you really create a robust infection control program for your facility. I'm going to show you an example of a toolkit on the next slide. So this is an example of two different tools that are published on CDC's website. It includes a checklist for contact precautions, for example, like ensuring is there signage posted? Is the PPE available at the room entrance? Is there hand sanitizer accessible for personnel? Another example of an ICAR tool could be whether or not the facility provides staff education on hand hygiene, PPE usage, environmental cleaning, and reprocessing of reusable equipment. All of these observational checklists are going to help you standardize the assessment, not only for us whenever we're on site conducting the infection control assessment, but also for consistency across your facility as well as other facilities as well. Next slide. So we're going to revisit our response steps. This final step highlights the importance of continuing screening and ICARs as needed. Once an initial assessment has been completed, a follow-up assessment may be recommended to ensure that those recommendations from the previous ICAR are implemented within your facility. We may stick around for a while, and I know it's really cumbersome with all of us working on different types of pathogens, but we want to ensure that we're mitigating that pathogen as much as possible within your facility. Infection control is not a one-time event. It requires continuous monitoring and reinforcement to address those gaps and maintain readiness. With that, I do want to show you all of our information that we shared today on one beautiful image on the next slide. So this is a visual summary published by CDC. It's the CDC containment strategy, and it shows how public health partners respond to contain, spread, and protect people. It starts with that rapid assessment of resistant organisms from our antimicrobial resistant laboratory network, and then laboratories across nationwide, including the private labs in the state of Texas. This is then followed by infection control assessments and colonization screenings to contain that transmission while simultaneously doing this across multiple facilities. This brings us to the most important component of the coordinated response between facilities as well. Public health teams play a critical role in ensuring rapid and aggressive containment actions to prevent the widespread transmission of antibiotic resistance. The wheel is going to show you how the containment is continuous, it's cyclical. Each process reinforces another step in the entire management and overall goal of just containing that antimicrobial resistant or multi-drug resistant organism within a facility. So let's highlight the key takeaways. Next slide. That was a lot of information, but I hope that it showed a lot. It showed a little bit more about the insight on what a healthcare associated infection investigation looks like on the public health side. Like I said, we're illustrating this through a Candida auris study, but it doesn't mean that this could be different for any other pathogen that comes through your hallways. We want to ensure that public health is here always to help you guys, and we're not here to report you, and we want to ensure that we collaborate with you guys for the betterment of patient safety. The first key takeaway is healthcare-associated infections, or HAIs, are a serious threat to patient safety. CDC does have an antimicrobial resistance page, and I heavily suggest that your team members take a look at that after this meeting. They have great resources that you can implement within your hospital, and they provide great educations as well for anyone who's willing to learn a little bit more. It is crucial that any notifiable conditions or outbreaks are reported promptly to public health authorities. As you can see, we not only follow up with your facility whenever we're notified of a pathogen, we're playing several different hats. We're trying to reach out to the facility that patient was admitted from previously before coming to your facility. We're trying to reach out to the discharge facility. What does this look like long-term wise? Are they going to be a resident at a nursing home? Then we're going to go ahead and notify that subsequent nursing home as well to make sure that patient is taken care of, but also we're protecting the patients around that patient whenever they arrive at that healthcare facility. C. auris is an emerging pathogen still, but it can spread rapidly in healthcare settings. I know many of you on this call may have had to care for a patient colonized or infected with C. auris, but we still have several facilities across Texas that have never had a C. auris patient. We are actively always educating our healthcare facilities on what C. auris is and how it spreads and why the containment is so rapid and necessary right at the beginning whenever it is identified. Public health partners are here to help, and we will help you contain investigations and outbreaks. We're only here to support your infection control teams and be that third point of view and help you out in any way that you can. Public health and healthcare facilities, we're not separate entities. We're a unified team, and we're stronger together in containing a disease transmission rather than just singled out. I want to leave off on a visual to help relay my message from today's presentation from my colleagues. Next slide. This is also a great visualization from CDC. And as we learned today, the work we do for infection prevention, it's not isolated. It's not in silos. Patients are moving between nursing homes, hospitals, and long-term care settings. So our actions must move with them as well. The common approach isn't enough. We're working in silos and that could lead to missed opportunities, delayed action, and just unnecessary harm. Even independent efforts, though they may be well-intentioned, they may fall short when we're not sharing this critical information between facilities regarding that patient's MDRO status. What we need is we need to commit to a coordinated approach. When facilities all work together, we supported by public health, we create that safety net that catches what individuals alone can't. And so that allows us not to be in the response-based mode 24/7, but also help proactively provide education and support to healthcare facilities as well. It's how we protect all of our patients. With all the conversations that we had today, we hope that the main takeaway that you should do is that every conversation that you have, every protocol that you implement within your facility, it all matters. And then together, it's the only way that we can actually make a difference in terms of advocating for our, not individual patient safety, but as a community as well. Our HAI outbreak inbox email is going to be highlighted at the end. So if you had any questions of what the public health response looks like for not only health HAI conditions, but in general, please feel free to reach out to us. We're more than gladly to send you any resources that we have and go from there. Thank you.
Great, thank you all. I know we're right at time. We're just going to do the learning activity really quickly, and then we'll share that information and open it up for all for questions. And if you need to hop off, that's fine. You can always submit your questions later to us too. So if you just want to quickly scan the knowledge check. Okay, great. So the first question is question 1. A person with CRS colonization has visible signs and symptoms of an infection. Is that A, true, or B, false? And feel free to put your answers in the chat as well. Or sorry, in Q&A. Okay. Question 2. When a CRS case is identified in an acute care hospital, which of the following isolation precautions should immediately be implemented? Is it A, B, C, or D? Question 3. Which of the following disinfectant is most effective for cleaning environments contaminated with CRS? Is it A, B, C, or D?
Dr. Rouge,
Yes.
I think the Q&A is off.
Can the participants see the Q&A? I'm seeing a thumbs up. Couple thumbs up. Okay. Okay, so I'm seeing yes. Okay. So for question 4, or do we need to go back and scan the QR code? Okay. Well, we'll finish it up and then we'll open it for questions. So for question 5. And then for question 6. Actually, we'll just skip through and then since it looks like we're having issues with the Q&A, we'll just kind of go into the wrap up and then have it if anyone has any questions. So for the outbreak investigation, the key components of what we kind of all talked about is prevention, identification, and elimination. So screening is highly, highly important, making sure that you know what to look for and who in your patient population that you're seeing, making sure you're identifying and isolating the organism of interest, especially when it's a highly pathogenic organisms, as we saw in this example with C. auris. So making sure that we have our isolation, we know what room they are, where they've been in the facility, along with collaboration and communication. So working internally and externally with our local and state public health officials and completing and disseminating this information with the interfacility transport form that we talked about. So we want to thank you all for coming to today's webinar. Here is our emails. You can email me at Teffy IPC, our DSHS presenters at their email at haioutbreak@dshs.texas.gov. And then here's the QR code for additional other Teffy course. And then our upcoming module will be presented next month on November 6th, talking about infection prevention and control in special populations. I asked for those who are still online if you can do the post-survey evaluation form is here. Along with next week, we are holding the IPC office hours. And which are open to anybody to talk about IPC communication, collaboration, and learn from each other. If you want this invite, please email ipc@teffy.texas.gov for the invite. Along with here are the instructions to obtain your continuing education hours as well. So now we'll kind of open it up. If there is any questions for those that are still online. I see a hand up. Are you able to put your question in the Q&A for the hands up?
If the Q&A is not working, I think we can unmute those participants if you'd like me to try that.
Sure, we can do that if the Q&A isn't working.
Okay. Seems like there may be an issue with entering Q&A.
Okay.
So we'll start with, I guess this is Zelda, is the first hand raised here. And Zelda, I think I just enabled your mic if you'd like to try. You'll still have to unmute yourself.
Hi, good afternoon, and thank you so much for beautiful presentations. But I couldn't go to scan because there was an issue, and it was not working QA section and even chat section. And it was great to hear from all of you and listen to great presentations. I just want to say thank you.
And it looks like the next person whose hand was raised, I apologize if I mispronounce, is Taherzadeh. We'll allow your mic and then you can unmute yourself to ask your question.
I'm sorry, I didn't mean to raise my hand, but I did think that the presentation was wonderful. Thank you very much.
Great, thank you. And the next raised is Cy Matthew. I will enable your mic and then you can unmute yourself to ask your question.
Oh, hi. It's okay. I was just going to mention or ask if I could have seen the QR code again, but since it's already passed, it's all right now.
That's great. Thank you so much. And then Bernard Kloppenberg, I'm allowing your mic and you can unmute if you have a question.
Hi, thank you, and excellent presentation. I might send a follow-up email for this because it's a little more technical. Um, I'm from the state of Florida Health Department in Polk County, and we're working on improving our MDRO surveillance. And I didn't know if there's a standardized line list format that you all use to track cases globally across facilities and abstract information from medical records versus a line list that you would use that's more facility focused. The challenge we have sometimes is Arcane Data Aura's case volume is really huge, and it's really challenging to find those epidemiological linkages between patients because the cases move across facilities so much. It's hard to kind of tell if a facility is having an outbreak or if these patients are coming from high risk settings. It's kind of like the chicken and the egg question. I just didn't know if you were aware of any resources that would be useful for local health departments to use for those kind of surveillance initiatives.
Yeah, that's a great question. So I heard two parts of the question. So the first half was whether or not we have any just data that we're sharing on a global level. We actually have a data team here at Texas Dishes, so they'll be actually a little bit more helpful than I would be. They're the ones who do the annual result reports and also clean up our data for us. And so feel free to email us and they'll be able to provide those reports and just so you can take a look at how we're reporting our numbers and what that looks like for the state of Texas. In terms of globally, I don't believe our team is monitoring that globally in terms of transmission, but we always use our CDC resources that are published and of course reach out to our partners at CDC for that information, but feel free to reach out to us. Who knows? They may know something that I may not know from that data team and we're more than gladly to help with that. The second component of the question of a line list, we don't have a line list that we've been able, it's kind of just throughout the years, all of our epidemiologists have developed line lists to see what functions best for CRS investigations. And so if you were to send us an email, we're more than happy to maybe provide a template or see if there's any published resources on our end that we have used before that have proven to be helpful for CRS investigations and see if they're applicable for your investigations at your health department.
Thank you.
Yeah, of course.
Great, and the final hand raised I see is Aina Amedu. I'm allowing your mic and you just have to unmute to ask your question.
Hello, good afternoon. Thank you for the presentation. It was an awesome one. I have a question. I work for Texas HHS, one of the supported living center. I have some clients that like they have hepatitis B before they were carrier, but now they're having the disease and they are living in the same room with other clients. I want to know if this is good or there is something that needs to be done.
Hi, yes, I don't want to provide recommendations on this call. I do want to take a look at this patient as a whole. Do you mind emailing us this and we'll see if we can loop in additional team members as well and provide those recommendations for that HPV patient within your facility and what that looks like in terms of cohorting for care and any roommates if that's allowed for them as well.
Thank you.
Yeah, no worries. Thank you.
Any other questions before we end today's presentation? No? Okay. Well, thank you all for coming. Thank you for our partners at DSHS for presenting today. I invite you all to come to next lecture. I apologize for the Q&A not working. Please fill out the post-survey evaluation for today's lecture, along with going back when you get the slide deck for the learning activity. And I look forward to all seeing you next month at our last TEPI IPC lecture of this year of 2025, talking about IPC and special pathogens. Thank you all for attending and have a great day.